Hello, and welcome to the Ovarian Club, a glimpse into conversations between two besties across countries, South Africa and France, tackling the trendiest women's wellness topics through a scientific lens. Join me, Dr. Tarryn, and health expert Emma as we explore delicate subjects related to the women's health space. We started this podcast to share our conversations to help navigate the complex women's wellness world. We hope you enjoy the podcast and take away as much from it as we've enjoyed making it. The Ovarian Club, powering life, nurturing health, shaping sustainable wellness. So, my follicle friends, let's begin. How's it, Tat?
Hello, Em. Happy Heritage Day.
Happy Heritage Day. And did you do anything to celebrate?
No, I'm actually dressed in my doctor outfit. I had to work, but it was a beautiful day out on the field. I was doctoring a football match and we won. So really happy about that. And I see we now have matching nails. Team red. Red.
Isn't there something like the red nail theory or something like that you like, you act more confident and you manifest more things if you have red nails?
Well, I'm manifesting that for us. So
manifest,
yeah.
Girl.
Team red, girl. Yeah.
I'm happy to be back with you. I feel like it's been like a minute since we recorded. I know you recorded when I was on holiday. And for those of you who did listen in on the last episode, funny behind the scenes story, Ta was trying to sell me on this topic of lube. And there I am, the prude, sitting there like in the gym of my hotel being like, don't make it sexual, don't make it sexual. And she's like, but we have to be open. And there I am being like, no, Tat, like calm yourself down and everything.
And I'm just begging her. I was like, please, I really want to, this content is so good and girls really need to know what to put in their vaginas and what's good for them and what's not. And Emma's like, don't say the word vagina. And I'm like, Emma, no. So anyways, it's really tough being co-founded with a prude. But you know what? Emma keeps us in check.
I like to think of myself as being more like conservative, let's say. I think it's...
Yeah. Emma's conservative, but you know what? We need good balance, and this is perfect because today's topic is a lot more serious, one which Em suggested. Yeah.
So it's a big topic, and it is a heavy topic. So we're going to be talking about genetic screening for cancer. So kind of the genetic markers that could suggest that you have a predisposition for certain cancers. And one of the reasons why we chose this topic more specifically is not only because how hugely important a topic it is, but it also has been Ovarian Cancer Awareness Month, and we're coming up to Breast Cancer Awareness Month. So we thought this is a hugely important topic. And I do feel that there is such a lack of understanding around genetic testing, which genetic test to get, who should be testing, who shouldn't be testing. I feel greatly differs also according to which country you're in. So I feel like it's a huge topic. And for those of you who don't know, before Tarryn became a medical doctor, she did study genetics. So before we dig in, just a couple of disclaimers. Views expressed during this podcast in no means, shape, or form represent the views of my company. And Ta, over to you.
Yeah, just a disclaimer on my side. Although I am a qualified medical doctor, this podcast does not serve to offer any personal medical advice. So always seek the advice of your own healthcare professional with regard to any treatment you may be seeking. And yeah, that's about it.
So, Tat, like this is a huge topic and there's a lot to dig into, and I'm not even sure where to kind of start. But I think some of the things I really want to unpack during this episode is a lot around breast cancer and ovarian cancer, genetic markers, the particular ones. But genetic markers, I believe, go much broader than just breast cancer and ovarian cancer, pancreatic cancer, prostate cancers, etc. So you do have the genetic markers for those, for also some of the men listening in on the show today. I want to understand, why do genetic mutations cause cancer? So what actually is it? We hear so much being thrown around genetic testing, genetic markers and stuff like that. Who should be testing? Very, very, very importantly, why should we test? How do we test? Like, how do we go about testing? What is being done in South Africa? What is being done internationally? What to also do if you unfortunately do test positive What action should you be taking? What steps should we be looking into? And what if you already have cancer? That's something that I'd love to understand. Is this test for you to understand, for your family members, etc.? So
So many questions.
so
Yeah,
many
I'm so
questions.
ready.
So many questions. Let's
Cool.
dig in. Can you kind of take us through a little bit
Yeah.
in very simple terms? And I'm the dummy over here that knows nothing about genetics to kind of break that down into simple terms. But tell me a little bit about genetic markers for cancers. What are we looking at? What are kind of the fundamental basics before we maybe go into the genetic testing itself?
I think let's start with basics. What is a gene? So genes are basically units of DNA, which are found in all living cells in our body. And essentially the genes code for certain functional mRNA, which then forms proteins. And the proteins basically govern how our cells function and how we and how they respond to their environment. And this, so it's quite an abstract concept to understand. It's very difficult to explain it in simple terms, but essentially genes are the recipes that basically dictate how our cells form and how we function. And cancers occur when there are mutations in these genes, which can be a result of either genes overly dividing and multiplying in the case of oncogenes that get activated and then they just divide. Or in the case of mutations found in what's called tumor suppressor genes, which are genes which in the normal circumstances would halt the multiplication of genetic material, but then they no longer work because the tumor suppressor genes are mutated. So then when they can't halt the brakes, the cells divide uncontrollably. Do you understand? So cancers can be genetic, as in the case of these oncogenes that are activated, or tumor suppressor genes that are mutated to no longer halt the process. But then they can also be somatic. So in other words, acquired. So UV radiation, smoking, HPV basically can cause cervical cancer, which is not genetic. Viruses, basically external factors that could result in somatic gene mutations.
And 2 questions quickly. You mentioned oncogenes. What is an oncogene? Sorry, that's tumor suppressor genes. That makes a lot of sense. But oncogene, what is that?
So basically, an oncogene is a growth promoting gene. So its normal function is to promote cell growth. But then if it gets mutated, it basically causes the cells to divide at an uncontrollable rate. They get overly activated. Then they basically cause havoc in the body.
And do we know kind of the split between the percentage? I know that they said around half of people that have breast cancer, that was caused by genetics, and the other half is lifestyle factors or chemicals or various different things and contributors. Do we actually have a breakdown overall and understanding about kind of what is that split? How much of cancer is caused by genetics? How much of it is caused by lifestyle?
Different studies point to different percentages, but my overall estimation is that 10% are germline, so 10% are genetic, whereas 90% are actually acquired, even pertaining to breast cancers and ovarian cancers.
So that's quite a huge
if you
percentage.
It's quite it's quite a small percentage that is that is genetic, in other words, that it's passed down in the germline. However, we've got such great screening for these genes, and I would argue it's still important to know if you are a patient at risk. It's important to know whether you have this gene or not, because it can be very aggressive, right? These cancers. And it's very informative to know if you have the genes beforehand so that you can actually take action and do something about it before it potentially develops into a cancer.
So who should be testing? Let's kind of jump ahead before we start going into some more of the specifics. Who should be testing and why? I mean, you mentioned the fact that, okay, maybe it is a smaller percentage that is caused by genetic mutations versus lifestyle factors. That's what's causing cancers, but still hugely important. If you know that you could have a genetic predisposition to cancer, maybe you could take certain actions to address that, and we'll get into that. But first of all, who should be the ones looking to test for these genetic markers?
So generally speaking, if you've got a strong family history of cancer by a direct first-degree family relative, so a mother or a sister, it is highly advisable that you start screening. If a family member developed a breast cancer that was like late into her adult years, say like after 60, then the risk is actually reduced. So it's not as strong a family history. But if it is a mother or a sister, someone young, it is a first-degree relative who got who developed cancer or breast cancer specifically, you are considered a high risk individual and screening is strongly recommended.
What do you mean by later on in years? So if the person were to get, let's say, breast cancer later on, do you mean later on in their age, or in terms of like the degrees of separation? Like my grandmother had breast cancer very young, and then she went into remission and then got it again.
Well, yeah, I mean, if she developed cancer at a young age, that would be considered a risk factor, but not as great a risk factor as if it was a first-degree family relative, so like a mother or a sister. Okay. Nevertheless, this is actually not so important for the patients to know about. It's very important for the doctors to know about because it's the primary care physician or the doctor who's taking a history with the patient should be the ones who can promptly identify these risk factors and then refer for genetic screening, where comprehensive questions will be performed with a genetic counselor who will really determine whether screening is advisable or not based on the relevant risk factors.
Okay.
But then in the case of BRCA, right, which is maybe we should talk about BRCA first, and then we can talk about the high risk.
Down.
Yeah.
Yeah.
So there's BRCA1 and BRCA2. The mutations in these genes are strongly correlated to breast and ovarian cancers. So these genes are tumor suppressor genes, which are generally the genes that should halt unnecessary cell growth. But when these mutated genes are inherited and passed on to the offspring, they can no longer halt the cell dividing process, and cells then divide uncontrollably. Now, BRCA1 and 2 can be picked up in a blood test. So high-risk individuals would include if you have a strong family history, that's the main one. But then in relation to BRCA1 and 2 specifically, if you yourself have been diagnosed with a breast cancer and you're young, so you're less than 50 years of age, or if you've been diagnosed with ovarian cancer and you're less than 60 years of age, or if you've got bilateral breast cancer, so in both breasts, it is highly recommended that you get screening done because it would have implications for both your treatment and also it'll have implications for your offspring because they might need to know whether they have the gene as well based on whether you have the gene or not.
How does it change the treatment? Just in the sense that they know which kind of genes to go for, or which treatment modality to go for?
Yeah. Well, I was just finishing off with the risk factors, but then there's also triple negative breast cancer. So if you've got triple negative breast cancer, that means that your breast cancer does not express the estrogen receptors, the progesterone receptor, and the HER2 receptors. And basically, this would have implications for treatment because the cancer is not driven by hormones. So the standard targeted treatments like endocrine therapy wouldn't necessarily work. So that's kind of in answer to your question. So it would have implications for like chemo and whatnot.
Okay. And then there's others who also have a higher predisposition to BRCA1 and 2 more specifically, right?
Correct. So other groups would include the founder group. So Ashkenazi Jews, that stem from Eastern Europe in origin, as well as Afrikaners, actually. So these two groups would also be considered high risk, at least in our patient setting. Yeah. So those two are other groups that should be flagged.
And that's more specifically for BRCA1 and 2 in terms of the broader genetic testing for cancer predisposition. If you have cancer, would you also be testing for all other types of cancers? If you, for example, do all other types of genetic screening if you had cancer, would that also apply? But the kind of founder group is more specific to the BRCA1 and 2, because I feel like that's the most spoken about genetic mutation.
Yeah. So other cancers that provide screening include colon cancer. So there's a colon cancer gene that can be screened for, and that also has a hereditary component. And if you are an individual that's considered a high risk group, it's worthwhile screening for that as well. Basically, when it comes to genetic screening using genetic markers, there can be very, very comprehensive panels. So in the South African setting, we try keep it cost effective, and we kind of hone in on the specific risk factors that you have, because otherwise you could just screen for every single cancer and it would be so expensive to look at every single marker. So
Because
you
there's
do have
around
to take
80
cost.
markers, right?
I mean, I don't know the exact number offhand, but there's so
Yeah.
many different markers that one could screen for. So this is why it is crucial to actually meet with a genetic counselor before, and instead of just paying exorbitant amounts of money unnecessarily. Like, a genetic counselor will actually take the time to sit down and do the screening with you, and advise you accordingly on which genes you should specifically screen for.
So just to kind of summarize everything that we've discussed so far, the oncogenes and the tumor suppressant genes could cause cancers. And then you have obviously the lifestyle factors, which attribute the large majority of percentage of cancer causes. That was complete incorrect English. But anyway, and then you have, more specifically the BRCA1 and 2 groups, which I think for some reason I feel have gained the most traction. I don't know if that's a reason why, but I feel like that's the most known risk type. I don't know if it's just that if you have this genetic marker that you even higher, greater predisposition to cancer, or is it just had more awareness and press?
I think, I mean, it's a good question. I think the BRCA1 and 2 gene mutations have gained a lot of traction lately because there's actually something that one can do about it that's like very actionable. Firstly, if you have the BRCA1 and 2, there's like something like a 50-60% chance that you will develop breast or ovarian cancer. So it's quite a high percentage. It's not a guarantee. So you might,
Yeah.
test for the gene and then you show that you have the mutation. It still doesn't mean you will get it, but the risk of developing it is significantly higher when compared to the average population. So there's that. But then I think it's also the fact that you can actually do something about it. So if you test positive for the BRCA1 and 2 mutation, you could have a double mastectomy, remove the breasts, even remove the ovaries and the fallopian tubes. I mean, this is quite extreme, but necessary if you are deemed a person at risk. And this could be life-saving. So I think, the BRCA1 and 2 mutations have gained a lot of traction for those main reasons.
And if you have other mutations, so if you test positive for other genetic mutations, would you still follow the same course of treatments? Exactly. So is that just more like frequent screenings that you could do, or you're just kind of flagged into a high risk group and then you follow, your doctor follows a different protocol with you?
Yeah, it would be a different protocol depending on what gene you flag positive for. But for example, like a colon, if you flag positive for colon, then you're going to remove your colon. You know what I mean? But it would have implications for like your family members screening earlier, or going for earlier colonoscopies. There's also prostate cancer, not relevant to our female population listening in, but there's like prostate cancer screening, genetic markers. There is pancreatic cancer. So it is helpful to discuss all these things with your genetic counselor, who will advise you accordingly.
And before I kind of go into what is available in South Africa and also kind of what is funded by medical aid, what is not, because I appreciate that that differs internationally. A lot is funded overseas. But I was reading about a report. They were doing some research at Wits University, and a large percentage of women of Southern African descent have breast cancer. And if I don't know the stat off the top of my head, but it's quite a high percentage of women that do get breast cancer. I don't know how much of it is to do with lifestyle factors, as you mentioned, but apparently there is another genetic mutation that is specific to women of Southern African descent. And there's something specific that you can also test for, and that is found to be a large cause of breast cancers and potentially ovarian cancer, if I'm not mistaken, too. Have you come across that research, or are you familiar with the BITS research that's been ongoing?
I do believe you sent it to me, and I must shamefully admit that I haven't read it, but I absolutely will read it as soon as I wrap up this conversation. Yeah, no, it's been so busy on my side, but there's so much research just going out there in general. I mean, I don't know if you've stumbled across this, but I've actually been reading up on these new tampons that are being developed that absorb your menstruation, and in doing so, it can actually pick up markers in the menstrual blood that could predisposed to certain cancers.
Oh, wow.
We don't have to get into the nitty-gritties of it, but I mean, there's just so much work that's being done in this space. It's like a constantly evolving space because, I mean, to date, we've been speaking a lot about breast cancer, right, which is so important. But ovarian cancer, arguably the deadliest of them all, often gets detected very, very late, stages 3 and 4. By then, the prognosis is a lot poorer
Mm.
compared to if it were to be detected in its earlier stages 1 and 2. So it's very aggressive. And to date, there is no single biomarker that can accurately detect it. There's talk of the CA125. Doctors listening in might, be aware of this marker. It's not the most specific, but it is, obviously if it flags positive high, I mean, further investigations would be warranted and it could certainly, raise the alarms. But it's just crazy to think how behind we are when it comes to ovarian cancers compared to, cancers that affect men. Sorry, I just get like really upset about it. Testicular
In what
cancer,
way?
testicular cancer, the ovarian counterpart, like well streamlined process. Okay, granted, it's easier to detect, like a lump in the testicle is easier to pick up than something internal. But yeah, I mean, the tumor markers, like they're well recognized markers, and it just seems like the cure rate for testicular cancer is so much higher compared to that of ovarian cancer. But I would argue that's because ovarian cancer gets picked up later, due to
Maybe
its
the testing
presentation, but
also.
also
Yeah.
yeah, and then due to like maybe lack of awareness and testing. So yeah, but a lot of work is getting done in the space, and it's actually a very exciting space.
Yeah, I think maybe also women tend to also diminish pain, or,
Mm.
they think it's caused by other things, or we're kind of used to maybe
Yeah.
sucking it up a little bit, or so.
Definitely. And I mean, ovarian cancer, the symptoms at least initially can be so vague. So like maybe bloating, early satiety, feeling full quicker, like a bit of nausea, maybe some weight loss. It's just like really vague symptoms. So people don't often think to report it to their doctor. And also doctors often gaslight their patients and like they don't like take proactive measures to go
Mm.
looking for things. And they don't take a comprehensive family history either, which is actually something I've definitely reminded myself through doing the research for this podcast. Like it's really crucial to ask about a family history. Patients aren't going to volunteer that information when consulting with the doctor. So doctors should really familiarize themselves with the various risk factors, and then also they should have a trusted genetic counselor on standby because there we have many operating in Cape Town, operating in Joburg, all the major cities. And yeah, it would be very helpful to then refer your patient just for further screening and genetic testing because we have this available to us. So why deny patients this?
What is available? Like in Cape Town more specifically, what is available, or Cape Town, South Africa more specifically, what
Hmm.
is available? I know that in the NHS in the UK, for example, I've seen people that have received invitations for BRCA1 and 2 testing because they're part of a certain ethnic group. They're Ashkenazi, or, they have a family history, they've been invited, it's free of charge,
Hmm.
everything is done. I know that in the States, certain insurance policies actually do cover the genetic testing. What is available in South Africa? What should people be asking their doctors for? What should people know?
So, in terms of what's available in South Africa, unfortunately, it's only in the private healthcare system. So, if you're in the public healthcare system, genetic screening, yes, it's available to you, but you'd have to pay out of pocket. And it can be quite expensive. Like, I think we're talking in a range of like 1,000 rand per person. I suppose if you bring in a family, maybe there could be a different price agreement. I don't know, but it's not cheap to at least go for that initial
Mm.
consultation. Certain medical aids most certainly cover for them. So it's worthwhile asking if you have medical aid coverage, what are the benefits there, especially if you have an oncology benefit because you've got you have cancer yourself, or because you've got a first degree family relative. Or every medical aid operates differently. But then it's not just the screening that's expensive, it's actually the testing itself. I mean, the panels can cost up to like 20,000 rand, especially if you're going to do a full
Wow.
comprehensive panel based on
Yeah.
what the genetic counselor suggests. That's why I'm saying, like, you're not going to just do every single genetic marker. It can be really, really expensive, the blood tests. So, it can be really expensive. But as I said, it's worthwhile just chatting with your medical aides if you have. This is unfortunately not offered in state.
And we spoke a little bit about if you test positive for BRCA BRCA1 and 2, BRCA1 and 2, you can explore mastectomies, you can explore having your ovaries removed.
Mm-hmm.
And we spoke about more, raising this to your doctor, raising this, going for more screening, having more, whatever it is. Is there additional support or help that is available for people that do test positive? Is there a different protocol that the doctors sadly do follow? I feel like it's such an important thing to know, but sometimes, ignorance is bliss. And I can just imagine what people must be going through, finding out that you do test positive for this, and that could mean that you're very likely to develop cancer later on in your life, or
Mm-hmm.
that's quite a heavy weight too. So just kind of understanding, there are steps and actions that you can do, but there's also support, or there's also things to
No,
consider.
definitely. I mean, that's why you go through a genetic counselor. This is why like doctors don't do these tests. Like you have to go through a genetic counselor who's like trained in not just like the genetics
Mm.
component, but the counseling component as well. And before you go for your testing, if it's even indicated, because remember, a genetic counselor will do the screening in more depth and then will actually advise whether it's necessary or not. There's extensive pre-test counseling that happens even before the test. So like the possibilities of a positive outcome is well established beforehand. So patients know what it's like before going in. But it doesn't make the anticipated outcome any easier. And
Mm.
that's why the counselors are really well equipped to deal with the diagnoses and refer accordingly to an oncologist or breast surgeon or whatever treatment, depending on whatever treatment's indicated.
So if people are going to go ahead and do these tests, there's saliva and blood, right? Those are the two main. I know you mentioned obviously the tampon that's in development, but in general, it's saliva and blood, right, as the two kind of main testing mechanisms. Go to a
Yeah.
lab, or you send in your
Yeah.
results and then wait for the results,
Yeah.
and then go through
Yeah.
that with the counselor.
So I'm more familiar with the blood tests. I'm sure saliva would work as well, but blood tests are more routinely done, at least in our setting. And you do that through the labs, and it can take up to 4 weeks,
Wow.
2 to 4 weeks to get results. It's not immediate, yeah. And if you're sending it overseas, it could take even longer. Like overseas will take 4 weeks. That's if you are choosing to do a very comprehensive panel that's not offered in our country. Should you just go for the standard panel with like fewer genes, but it's more specific to your needs and within your budget, yeah, I'd say like 2 to 4 weeks on average, the wait.
What genes aren't covered by South Africa? Is there
I'm
anything
not a,
very niche?
yeah, it's like some of the rarer mutations that aren't prevalent in our population. It doesn't mean that you won't get it, but it's just because it's considered rare, it's not routinely offered here. But yeah,
Hmm.
there's like a long list of genes.
A huge topic,
Yeah.
and I think something that is hugely important, especially as we are seeing the rise. Obviously, the lifestyle factors is still something that you have to consider. And I think that just because you test negative doesn't mean you don't have to still watch out, do your self-testing for breast cancers, monitor your symptoms, go for your screenings, do the right
Hmm.
steps, right? Because I think that's also very important, that if you test negative for some of these markers doesn't necessarily mean you're in the clear either. You still have to follow steps to make sure that, yeah.
Sure. Because as we said, you're picking up just the 10%, right? Like from the germline, but 90% of the time it's somatics. And then, yeah, I mean, it's a very big topic. I tried to simplify it as best I could, but it's quite complicated, quite deep to get into. But just as a reminder, and we certainly won't cover it today, but perhaps for a future episode, we should talk about screening in the form of like mammograms and breast ultrasounds
Yeah,
and like how to feel your breast, because we did put out a Q&A and we love their engagement. So thanks so much, guys, for all your questions. But yeah, some people ask like, how do you self-assess for breast lumps? Well, we didn't have time to get into it now, granted, because we had quite a big topic to cover, but for sure in the future we should flag this as a future conversation.
absolutely. 100%. Definitely want to kind of dig into more. I think we've spoken about a lot already. I think we've covered the different types of genetic mutations, onca, tumor suppressors, who's relevant, who's applicable if you've got your mother, sister who has unfortunately had cancers to test for these genetic markers. Ashkenazi Jews, Afrikaners, I believe that there's a much higher risk and predisposition to these genetic mutations if you are part of these ethnic groups. So definitely do look into that. And it is hugely important because it means that if in the event that you are testing positive, you can equip yourself with the tools to actually prevent this early on. So Ta, thank you so much. I know it was a heavier topic, but I think hugely, hugely important topic. And it's something I'm definitely going to look into more. But I really appreciate discussing this with you today.
Yeah, thanks, Em. And that's a wrap. So looking forward to chatting all about what's our next topic, by the way?
I don't know. I feel like we have a couple of ones that have been thrown out. Ozempic,
Yeah.
the pill,
Ozempic,
the pills
the
one that we
pill.
also mentioned.
Coming your way. Yeah.
If you do want us to cover any topic specifically, please do reach out to us because we love to hear from you. So please do let us know. And please also follow us on Instagram, TikTok, and don't forget to hit subscribe. That really does help us a lot.
Yeah, please hit subscribe. Don't just listen. Don't be that background person. Hit subscribe. We know you love it. Leave 5 stars, why don't you? Leave 5 stars while you're at it. Anyways, that's it for today, folks. The Ovarian Club. Powering life, nurturing health, shaping sustainable wellness. We'll see you soon, follicle friends.